Please don't die. Please don't die. Please don't die. Now, is this too graphic for Scott Carney Investigates?
I have tension listening to this.
All right. The stressful experiences for an emergency doc are probably different than people would think. You might think, oh, it's the shootings and the stabbings and these super sick patients. Those are the best moments.
What have you pulled out of people recently?
The most memorable for me was an industrial-sized can of oven cleaner with cap still on that took up somebody's entire abdomen.
Jeez.
Most of the time, people say, I have a dildo in my rectum and I put it there. When their partner put it in and they come in with their partner, those are kind of the most interesting stories. Or there's a recusing glare across the room about
You did this to me and it's still on. What is the best way to remove a rectal foreign body before you go to the doctor? So right now I have 8 pages of multicolored instructions on my desk. There are whole paragraphs that are bolded and underlined and shot through with red with like these crazy cautionary notes on it. And there's so many that are like bolded or in green or with like stop signs on it that I'm not really even sure what part of the instructions is the most important. They all are screaming at me all the time. And I just want to read you, just from the sort of the beginning of it, just a little bit of instructions at the top. And it says, you must limit raw vegetables and avoid nuts, seed, flax seed, and popcorn. These foods can negatively affect your examination. You need to arrange transportation since you will receive anesthesia and sedation and may not drive home or take a taxi or a bus service. You must be accompanied by an adult. One day prior to the procedure, no solid foods upon rising. Avoid dairy, alcoholic drinks, and avoid red, orange, and purple liquids. And then just a little bit down there, take bowel prep. You will need to clean out your colon, so follow the step-by-step instructions. And from here, things, they get pretty intense. We're talking about laxatives. We're talking about a metric shit ton of Gatorade. We're talking about something called Miralax, which I'd never heard of before, and something called Duralax, which I still don't know what it is, but in about 3 hours, I'm going to have to take 4 of those pills. That's right. Tomorrow morning, I'm headed into my very first colonoscopy. It's a rite of passage that, according to current medical guidelines, should happen right around the time you hit your 45th birthday. Remember when you were like 16 and you got to drive, and 18 you got to vote, and 21 you got to drink alcohol? Well, friends, at 45 you get your first mandated, insurance-covered colonoscopy. And I'm 45 now. And it's vitally important to do these sorts of things because they help minimize the risk of colon cancer. And I would also say it's generally a good idea to take a look at your insides once in a while to see if you're ship-shape. And so I don't know if it's entirely a coincidence, but I scheduled this podcast one day before this great event with my guest today, who is something of an expert on removing large objects from people's rectums, which is a topic that at least, I think we can see how that's tangentially related to the procedure I'm going to go through tomorrow, where essentially they take a telescope, a periscope, a giant snake-like object and inspect my insides. Today, I would like to introduce you to the Reverend Rob Orman, who has spent 25 years as an emergency room doctor, and he's host of this awesome podcast called the Stimulus Podcast, which I've been on a couple times. And if you already don't like the sound of my voice, don't worry, just go click the link to his podcast at the bottom of my show, and then you can listen to his voice if you like his voice better than my voice. But either way, we're going to start off with what was his most popular podcast that he's ever done. We're not going to run that podcast, but the very first podcast he did was on something called rectal foreign bodies, which is, well, Rob, what is a rectal foreign body?
A rectal foreign body, that is something in the rectum that doesn't naturally go in the rectum. The rectum is generally meant to be a one-way passage with poop and the light coming out of it. And granted, not that there's anything wrong with things going up in there, but when things go the opposite way, that would be a foreign body. So technically, you getting your colonoscopy, that colonoscope, that would be a foreign body, albeit short-lived. And fortunately, it's tied to something else so that it can be easily removed. So when we
and I really appreciate that about the colonoscope or whatever you call it. Like it removes easily, right? It doesn't stay. It doesn't stay.
Yeah. So when we're talking about rectal foreign bodies, what it generally implies is something that is not removable easily by at least the person who put it in there or the person who it's in. So it's kind of stuck in there.
Mm-hmm. And as a ER doctor, that is one of you probably get asked by other doctors all sorts of things about, what do I do when someone comes in with a broken leg or like a femoral artery, which is spurting. But probably the most common question that ER doctors get is really, what have you seen shoved up people's butts, right? I mean, that's going to be the question that, that's a great thing to talk about at a bar. And this podcast today is something like a bar. So before we get into some sort of more medical stuff, what have you pulled out of people recently?
Let me rewind that a little bit because there's a couple of levels in what you just said. So my brother and I, way back when podcasts first started, like 2006 or something, it was actually his podcast and we started podcasting, and I was actually on a cordless phone and it was really janky, but it was one of the OGs. Did that for years. And then I started a medical podcast and we were planning out the first episode, and it was going to be medical, made for ER docs specifically. And he said, okay, well, what are you going to do for your first episode? I said, well, maybe I'm going to do controversies in stroke management or how to evaluate a child with a potentially infected hip or management of sepsis in the elderly. I mean, and he was falling asleep. He said, you're a total
boring
idiot. Exactly. I know. And I'm thinking, this is the hard-hitting fact-finding info people want to hear. Investigative journalists, right? You see, I got my own Vortex back here. I'm an investigative ER journalist. And he says, listen, what do people ask you about at cocktail parties? I said, oh, rectal foreign bodies. Boom. There's your first episode. And so that's how it came to be the episode number 1. And I don't even do this podcast anymore, but it was on all emergency medicine stuff. And this was rectal foreign bodies. And so you asked me what my foreign bodies are that I've taken out.
What's your favorite rectal foreign body? That's really the question.
Okay. I need to talk them out. Okay. As it goes. So
is that the method when you find them, you have talked them out? It's like talk therapy. Like, come to me, rectal foreign body.
I did become kind of the rectal foreign body whisperer after a time. And there was a moment when I ate spinach with Popeye, but we can talk about that if you want to. I can just leave that hanging.
I think, yes.
So a lot of dildos, a lot of vibrators. I think the most memorable for me was an industrial sized can of oven cleaner.
Whoa.
Took up somebody's
oven cleaner
with cap still on, that took up somebody's entire abdomen. And
oh my God.
That
sounds A, toxic, and B, and do you get a chance to talk to the person after? Like, so how'd this show up there?
Well, sometimes,
like, I get the dildos and the vibrators. I understand what's going on with the dildos and the vibrators. That makes we all have been on the internet before, but how does the mega oven cleaner show up?
It is important to know. And I'd say about a third of the time you get the actual story. And when this comes up, when you're working your shift, so you're seeing chest pain, broken arms, head
Mm,
injuries, people with all kinds of infections, all the usual stuff you see in the emergency department. You're carrying 10, 20 patients, just depending on how the day is. It's a normal flow. And then you see pop up on the tracking board, which shows you all the patients who are waiting and the patients to be seen and are seen. It shows you the chief complaint. And you'll
mm.
usually see when this comes up, it will say other. You've got
Ah,
chest pain, abdominal pain, head injury, other. And sometimes they'll put up rectal FB. You'll see that, or it'll say other.
mhm.
And I, I don't know if this is good or bad, but I generally rushed to be able to take care of these because I thought they were always so interesting and such a challenge. And sometimes okay, this is going to sound horrible. Sometimes my partners and I would arm wrestle to see who got to take the rectal foreign body. Well, one is because it's interesting. Number two is that there's not any detective work to figure out how to actually what's going on and how to remove this thing.
Right.
And so you're going to say, well, hey, what happened? And it's very professional because it's not like it's this event that exists in isolation. It's just in the run of mill of your day. And so about a third of the time, let's say, oh, I have a dildo in my rectum and I put it there. Most of the time, people say, I slipped and fell. I slipped and fell.
Yeah. And that's a real danger in the world. If you're like cleaning your oven, okay, and maybe you were also mopping the floor earlier. Things are slippery.
Yeah.
It can happen. All I can say is it can happen. I was reading statistics on this before we did this show, because I knew we were going to be talking about where things ended up. And there was this great NIH study between 2010 and 2019 that calculated the number of rectal foreign bodies pulled out in the NIH. So the NHS. So this is in England. And they found 3,500 rectal foreign bodies were removed in the course of 9 years that were then recorded. Of those, males slipped and fell on their bottles of stove cleaner 85% of the time, and only 14.9% were females. And it was one thing that I loved about anything that comes out of the NHS is that they said this cost a total of $300,000 to the NHS, and I was like, wow. England's medical care is so affordable.
I thought you were going to say $300 million.
No, $300,000. And in the States, I was like, okay, is there like an equivalent one in the United States? And they found that 885 cases that had been detected by them, which makes me feel like the U.S. doctors were not doing enough work to analyze the cases, since there were so many more in England, which is a smaller country. Um, uh, but again, 77% were male. And what they found, and they also like listed a series of like what the most common objects were, and by far it was the vibrator and the dildo, right? Those were the top players, accounting for almost 68% of the total. But they also had nail varnish vials, glass jars, apples. They said
Apple's
apples.
really common, surprisingly common.
Okay, so and then also dentures and roll-on deodorant and ceramic candle holders, and there were others as well. So what's going on with apples?
Yeah, when something is cylindrical, it kind of makes sense.
Mm-hmm.
But the apples, I don't know, my wife had a case series of apples. She's also an ER doc, had a case series of apples. And I asked her that, what's up with apples? And she said, I have no idea. But getting back to how these things happen, so there's the slip and fall, and that if somebody says they slipped and fell, in general, they put it in themselves, and that's fine. Okay,
Mm-hmm.
that's usually how they get there. Sometimes it is an assault. And with that
Mm.
oven cleaner, this guy said, yeah, I was assaulted and this happened. And he
Oh
described it.
my God. I feel so bad about making jokes
No,
now.
I was just I couldn't even figure it out. I said, "How did you get that in there?" He said, "I didn't. I was assaulted." I thought, "Whoa, that." And that's what you need to know, because if someone is assaulted, then the entry of the rectal foreign body is much more likely to be traumatic. And so you can get
Mhm.
perforation of your colon from these. You can get it from it going in, you can get it from it being there in a long time, you can get it from the extraction techniques, but really, I don't care if somebody says they slipped and fell, or they put it in, or their partner put it in. When their partner put it in and they come in with their partner, those are kind of the most interesting stories. Or there's a recusing glare across the room of how this
You
thing
did this to me, and it's still on.
which kind of goes to, and we can talk about how to get these things out, but at the very end of the visit, if you're able to get it out in the emergency department, with an IV drug user, if they come in with an abscess, this may surprise people, but you have a discussion with them about how to, if they don't want to stop using IV drugs or they're not ready, you have a discussion with them about how to safely inject IV drugs. And that
Oh.
sounds crazy with,
Mhm.
hey, you're injecting heroin. Are you ready to stop? Would you like to talk to somebody about treatment or rehab? No, I
Right.
can't stop. I'm not ready. Okay, you've been here 5 times with a shooter's abscess. Let's talk about how you're shooting up, because that's harm reduction. We had harm reduction
Right.
during COVID.
Mhm.
And so
Mhm.
harm reduction with the rectal foreign bodies, so I'd say, all right, first off, do you want this back? Because sometimes they can come with a repeat of this. It's a
Right.
50-50. But then
Mhm.
the question is, next time you do this, what's your plan? How are you going to play
Right.
this out? Because I'm going to
Mhm.
recommend 2 things. Get something that was designed for this and has a
Mhm.
wide base, or at least a string so that you can pull it out. And so we'll talk a little bit about harm reduction. We'll talk about what do they want to do the next time so that this doesn't become an issue. Because it's usually a spur of the moment thing when it's like, oh, this seems great. Let's put this in there. And then
Right.
there's there's suction that develops, or vacuum, and just sucks it right in there.
Oh, so when you start putting it in, and I'm not very experienced with this, but it can go and and just sort of disappear, and you're like, "Whoa, that was a little surprising," and then you can't get it out.
That is by report. Now, whether that's true, whether it was just kind of pushed in, because once it gets in there, there can be a little bit of suction and vacuum, and it makes it hard to pull it out.
Mhm.
So I don't know that it's like a vacuum cleaner, but when patients have told me that, okay, here's what happened. I was putting it in, it was kind of almost in, and then all of a sudden it just sucked in. Now
Yeah.
that could be the contraction of the anal sphincter, just kind of
Mhm.
just massaging it in.
Mm.
But alas, harm reduction.
So, there's other things that I actually wanna talk about on this podcast, but I do want to know, how, I mean, I'm sure there's surgical methods to
Yeah.
remove a thing, and I actually don't know if we need to go into the surgery, but
Right.
what is the best way to remove a rectal foreign body before you go to the doctor?
I didn't see that question coming.
See, this is not a doctor's podcast, so we're here for the listener, okay? We're here for the listener.
I don't know. I'm just gonna tell you how I do it,
Okay, great.
because what happens is, so one, I mean, back in the 90s and the early 2000s, this happened a lot. I when I retired from clinical emergency medicine 3 years ago, and in the last 10 years of my career, I think I saw 1 in the last 10.
Oh,
Whereas it was a
fascinating.
regular occurrence. And now maybe that was just where I was working,
Mhm.
but I remember seeing a farmer. He lived in a remote area, and this kind of led to his issue. And he had a foreign body in his rectum, and he had been trying to get it out for 3 weeks.
Yeah.
And things just were bad. It was just bad.
Yeah.
And what
Yeah.
also can happen is when people start trying to take them out on their own, they can scratch the mucosa or
Yeah,
scratch the
intestinal
inside of the
lining.
rectum.
Yeah.
It's not good. So here's how I do it. And a key of this is that to grab it, it pretty much has to be in the rectum. So you've got your colon will experience this tomorrow.
Thank
So
you. Thank
when
you.
you go in, you get the rectum and it's a straight shot.
Uh-huh.
And then it takes a bend, like a hairpin bend into the sigmoid colon. And that's really a defining line for removing rectal foreign bodies. When it's still in the rectum and it's like this, you can often pull it out. Once
Okay.
it makes that curve, it's really hard to just get it out on your own or even get it out in the ER. So that's kind of the first point. If you can feel it, oftentimes you can get it out. But what can also happen is when you're trying to
When
get
you
it
say
out.
feel it, you mean you put your fingers in and you can feel it. That's what you
Yeah,
mean, right? Or you
yeah,
feel it, you're palpitating on the abdomen.
exactly.
Yeah.
Well, sometimes, yeah, if it's really big, you can feel it on the abdomen, but usually you stick your finger in the rectum and then you can just feel the base of it.
Mhm.
And one of the challenges, if somebody has a vibrator in their rectum and it's still on and you touch the back of it, it can be like a little fish and it can kind of swim away. So that can be really fraught if you're trying to remove an active vibrator.
Yeah, do you have to can you have a technique for turning it off because there's a dial on the back or
I've
something? You're like,
tried it.
maybe we'll
I've asked people, say, do you know what's the mechanism and how I turn this off? And it was often this kind of doubt, which was really hard because you're slippery and you're just trying to use two fingers in there.
Yeah.
I definitely did try to do that. I never effectively did that. And that was I would have an assistant pushing on the belly so that the foreign body would kind of,
Wouldn't spin. Yeah.
wouldn't spin and it wouldn't try to run away. And it would also kind of
Mhm.
push it down towards me a little bit. So I almost always had an assistant on the belly pushing down. And with lots of lube, lots and lots and lots of lube.
Yeah, I
And
imagine.
one thing we can do in the emergency room, which is hard to do at home, is we do what's called a perianal block, which is this is not comfortable. We'd inject anesthesia around the entire anus to relax it. Now, is this too graphic for Scott Carney Investigates?
I don't know, listeners, could we vote down below in the Spotify vote? Is Rob Orman of the Stimulus podcast being too graphic? And him being too graphic, does it make you want to turn off this podcast, which you can vote by? I can watch the statistics, or is he going to get a subscriber increase here as people flood to his very medical, stimulating podcast?
Okay. So we would do a block. And if this is too much medical detail, just stop me and I'll get to the retrieval. So we do that so that the person can be relaxed because there can be a lot of tension and anxiety with this. Give them something, some medication
I
to
have
help them
tension
relax.
listening to this. I have tension listening to this.
All right.
Okay.
So let's cut to the chase. You got your block in around the anus. You've given them some medication just to help them relax a little bit because first
Mhm.
off, there's anxiety around this. It's really uncomfortable, as you can imagine. So you get in a finger, then you get in another finger. I try not to put in more than that. You know, when you get in two, you're doing okay. Once you get in more fingers in that, then you can start damaging the anal sphincter, and that could potentially lead to incontinence or damage to that
Oh, that would
super
be bad.
important valve. I mean, if
Yeah.
you think about it, that is probably one of the smartest muscles in your body, the anal sphincter,
Okay,
because
explain.
it just by reflex
Mm.
can discern solid from gas from liquid. It doesn't always get it right, but think of the intelligence within that sphincter, the incredible job it has to do.
I have never thought about that, but as I take my Gas X or whatever this is called, this Miralax today, and my Miralax, my Ducalax, my Gatorade, my Gas X Simethicone, I don't even know what this stuff is. I will not report back to you, but I will have learned something about this.
That is the most aggressive colonoscopy prep I have ever heard in my
Are you
life.
serious? Oh
Yes.
no, I got the aggressive one. I've heard some people drink this stuff, which is like tastes like I think they said like petrochemicals, and that
Yes.
makes them it goes through. But no, for me, it's all over the counter stuff, but it's a lot of over counter stuff, and I have to wake up at 2 a.m. to drink a lot more of this stuff. I think this is going to be a miserable evening, and I'm going to get hungry because I love breakfast, and I've already missed one breakfast, and I'm going to miss another one. All right, so you get your 2 fingers in and you pull it out, miracle, and this person goes home.
In a good case, sometimes it's hard to get out because there's maybe a little bit of suction, which is debatable. Talk about a lightly held belief. In medicine, the only studies done in this really are case reports like that one that you saw from the NHS. This is a lightly held belief because it's all just, here's how we did it. Here's how we do it. So everyone kind of has their secret sauce about it. So it's your fingers act like pliers. People are watching the vodcast of this, like, this is the technique here.
Oh, and I like that. That's
because
like a hook. You like hook your fingers and you flex them. And if you can get a good grip, and I guess your lateral movement on your fingers is going to be a valuable thing. So if you do hand workouts, this might help. And then you pull it out. All right. I think that's enough detail for the rectal foreign bodies section. Okay. But I have a related unprepared question, because you've raised an important point, believe it or not, that actually dovetails with other things that I've talked about on this podcast. And let me give you a little bit of context. Okay. So Gwyneth Paltrow has this Goop Lab, sort of pushes wellness to its limits. Some of her stuff I think is really good. Some I think is way out there. And she's very controversial among sort of expert doctors on the internet who more or less hate her. And there have been multiple world-renowned doctors who have lambasted her for selling an object on her website called the yoni egg. Now, the yoni egg is a jade egg that women put into their vaginas, and it supposedly tightens up muscles, and it supposedly has some health benefits. I don't know. I've heard both sides, but because it is an object that you put into your vagina, the doctors use this as an instance of her just doing crazy wellness stuff that is, of course, terrible. Can't believe someone would put an egg in their vagina. Ha, 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 Gwyneth Paltrow. And to this, I want to say, I'm actually pretty open to weird wellness things. I think as long as it doesn't hurt you, it's not a problem. And the objection against the yoni egg is often, hey, it's a weird thing. It's a weird thing that you're doing, and we don't think it helps. But does it hurt? And since we're talking about rectal foreign bodies, I guess we can talk about vaginal foreign bodies. Are there any incidents of something like that hurting?
I'm going to tell you what comes to mind for that. I don't know the size of the yoni egg or what it actually is. I believe it's
about like I think it's like an egg size.
Okay.
Like a normal, like it's like an egg, and some of them I believe have strings that you can help pull out.
So if we're going to keep on the foreign bodies, I have removed many vaginal foreign bodies, things that just kind of get stuck up there. The vagina is one of the things it's designed for is for a baby's head to fit in it. Although there's hormones that help relax it and things can stretch. So as I think about it, I don't know about the yoni egg specifically. As I'm thinking about it, what would make sense is sounds like a Kegel exercise, that if you're just kind of, you have something to contract against like you would in a Pilates class or something. So I don't know, but I think that would be a perfect example of a lightly held belief that, oh, here's this thing. Because if this had been, I think Gwyneth Paltrow has all sorts of non-medically sound ideas. But if we're talking about this thing, if it had come from India 5,000 years ago, and now we use this ancient practice of how to strengthen pelvic floor muscles, oh, then maybe it's a great idea because it's rooted in such history. So I don't know. I mean, I
believe it's not. I believe that I think that the way they advertise it, that I think they say that there's like ancient Chinese princesses use the yoni egg. I think that's on their like marketing. But then there was a whole clinical article written in like a real journal being like, we have no evidence of vaginal eggs being used in ancient China
Yeah.
because people are angry at her about the egg.
I'm not sure what to say. It seems like it would be something worthy of study. Like it has some face validity as an object to push against.
Mm-hmm.
But what happens with these things is that they're posited as science when really it's just maybe it'll work, maybe it won't. And then people believe it as science. And then that becomes their strongly held medical belief that, oh, this is the way that it is and that this is right. And I think that that's where the conflict comes.
And I want to just appreciate you saying multiple times here that you're referencing an earlier podcast I did, which was called "The Power of Lightly Held Beliefs," because we did a show recently, like a month ago, right?
Yeah.
Was it a month ago?
About
Maybe
that,
it's
yeah.
even. And I'm wondering I think it was episode 8 on my feed, Power of Lightly Held Beliefs, which is really this idea that we should take, we know a lot about the world, but there's a lot that we don't know about the world. And a lot of that's based on assumptions. So it makes sense to hold beliefs lightly and use that idea of a lightly held belief to push boundaries. But then when data gets available, you can then reassess those ideas. That's the idea with lightly held beliefs. So I appreciate you bringing that up multiple times. I think I hit a nerve with you. I love it.
Oh, I just had somebody just came over to my house yesterday. We're getting a new hot tub. We're going to have our whole thing. We got our sauna, our DIY cold plunge. And now we're getting a hot tub. We're getting the whole spa out there. And he said, "Oh, I didn't really know him. He said, I listened to that podcast of you and Scott Carney, and I love the power of lightly held beliefs." And so
Nice.
it's a massacre of movement that's happening.
Love
with
it.
this thing.
Love it. Love it. Okay. Let's ask
Did I
some more.
address the egg? Did I address the egg sufficiently?
I think as much as you maybe could have. I mean, I think that some of the criticisms are that some people have said that it could cause infection, and that to me seemed unlikely considering it's a jade, right? And I mean, no more than anything else, like no more than sort of above the potential of other things that may go in there that could also cause infection. I would say it would be a lower incidence
Yeah.
than that, and I don't know. It just seems to me like it's a bit of medical hypocrisy out there. And I don't mind dunking on Gwyneth Paltrow sometimes, but I do think that when we do that, we should do it not from a place of just antipathy, just like because she's Gwyneth Paltrow, because she says something that's out of the norm, therefore she has to be bad. And I think she's been pilloried for that quite a bit. And I think it's better to look at evidence. And so I've actually asked several of these major critics about this question, and they've never actually presented anything. Although they will repeatedly, they used to tweet, but now they X about this issue. So you answered that about as well as I could have hoped, unless you were like, oh yeah, I pulled these out all the time. You don't even know how dangerous these are. So let's talk now about, I think a thing that many of us as, humans, or not everyone's an emergency room doctor, right? But being an ER doc it's sort of like constant low to high level stress. And these are things that you have to manage, you have to deal with. And sometimes it's exciting because stress can often be exciting. And sometimes it's probably debilitating because stress can also be debilitating. Well, why don't you tell me some of your sort of most stressful experiences as a doctor? And if you can also include here how you sort of keep level headed in these incidents.
The stressful experiences for an emergency doc are probably different than people would think. You might think, oh, it's the shootings and the stabbings and these super sick patients. Those are the best moments. Now, granted, that is the worst moment of someone's life and they may be dying, but that's what you train for. And that's why you're there. So when you're a patient in the emergency department, you have this snapshot of a doctor coming in and out and a nurse, and this team comes in and out. And that's your perspective of this is taking a long time and They seem kind of rushed. And then outside of that doctor, and I'll just take it from that perspective, has a lot of patients, and you are seeing new patients. You're trying to discharge patients. You're taking calls from consultants. You're taking calls from outside hospitals. You're trying to document, trying to interpret data, and you've got probably 1,000 individual data points at any one time that you're juggling, and they keep coming in and changing. And then you also have procedures to do. And so you have all of this stuff that is you're trying to internally triage and get done. And you can't do it all at once. And a lot of times you're just trying to keep your head above water. And at that moment of the patient encounter, be compassionate, be patient, and listen. And when you start your shift in the beginning of the day, I mean, at the beginning, I would feel like a holy man. Here I am, just the Dalai Lama got nothing on me. And then about 7 hours in, you've got that same patient like, oh, come on, please, just give me the story. I don't need all the accoutrement of all this. Just like, let's get things going. And those open-ended questions become very focused questions. And so there's also on top of that, I mean, that's on a good day. Now, after COVID, with the clients I work with and that work through a lot of these things, is there's a lot of incivility. There's incivility from patients. There's incivility from other doctors, from the administration. It's just, there's less grease in the system. You have a full emergency department and a full hospital, and you need to transfer somebody. So you end up calling a hospital. And it used to be, oh, I'll transfer them to this hospital. I'll take them and bing bong. Now you've got to call 7 hospitals. And that's another thing that's added on. And so all of this is just depleting your parasympathetic or your sympathetic nervous system. You're just sympathetically active all of this time, and you're carrying so much stress. And so how you deal with it, there's many different levels. There's the personal domain, the professional domain, trying to change the systems domain.
Well, one thing that's really interesting about what you just said is, and I expected you to tell me about a marquee story, right? A story about you having to deal with a sort of a heroic incident, which was very difficult. And I bet you will shortly. But I find it fascinating, and I get this, that when we talk about stress, where you went wasn't the event, the acute event of the thing that was really bad, and then life hung on the line. But it's like, dude, being a human in the modern world, dealing with our bullshit, talking about, I don't know. I had to fill out like a bunch of paperwork, and then I had to get on the phone. I don't even know. Someone's bleeding out right next to you right now, and you have your finger in their like carotid artery or something, and you're like, oh God, can you believe what Janet said about our medical procedures and how we have to now put our gauze in a different locker? Oh my God, like that was what you were you keyed in on here. And I think to some degree that's all of us, right? It's like, it's the mundane stuff. No, give me a gushing carotid artery.
Okay.
Please.
I know, you're at the water cooler. It's like, can you believe Steve today? That guy? Oh, not even on vacation, guy hardly works. Okay, so you have these moments of when I was saying before, is it's not the critical care moments of managing or stabilizing somebody who is on a trajectory to dying. And a lot of times that is where people die, is in the emergency department. And sometimes there's nothing that you can do about it, but sometimes there is. And so for example, I was starting out a shift. It was 7 a.m. and my partner was finishing up his night shift. And we're just kind of talking, and we're doing sign out where he's telling me about his patients, and things are pretty slow. And we get a call over the biophone, which is where the ambulances call in. And at the same time, the police call in. And we're getting these 2 messages at once of this, something big has happened. And what happened is 2 state patrolmen have pulled over a guy for, I don't know what, speeding. They come up to his window and he opens fire on the state patrolman. So one of them is shot multiple times.
Jeez.
The other state patrolman kills the perpetrator, which is important because we're wondering how much trauma we're about to receive.
Right. One patient or two. Yeah.
One patient, 2, 3. And
Right.
it's really interesting when you have these situations in the emergency department, you deal with injured police a lot. That's where they come. And sometimes you will have in one room, the officer, and the other room, the perpetrator or the suspect. Wow. And you're going back and forth. And I mean, I can remember in other cases, I'll get back to this, but in one room there, I had a guy who had kidnapped 2 kids and had kept them for weeks. And it was really bad. Bad things happen. And the cops found him and they worked him over. And so in one room, I'm sewing up his lacerations. And in the other room are these kids. And so you have these,
oh my God,
kind of these dichotomous mind states. And you think, I just need to be professional. I need to be professional here. And
right. And so you're treating the kids for whatever injuries they may have.
Yes.
And you're treating this guy who was beaten up by the cops and is a criminal, likely suspected criminal. Right.
Yes.
And we say suspected because of liability, but the dude was probably a criminal, right?
He wasn't denying it in the emergency department. So yes. And interestingly, with him, I felt this was a pivotal moment in my career. I felt such hatred for that guy. Now, granted, you were supposed to treat everybody the same. And I was so angry about what he did because I was just, treating these kids. And I went back in to talk to him and he said, hey, there was another doctor in here who was super kind and what a cool guy and all this. And it was my residency director. It was my boss. And so I went out, before I just went out, I said, hey, what was going on with that guy? He said, oh, I just went in and I talked to him and I was assessing his injuries to see what happened. Like, oh, he said you were super cool. I said, yeah, we were just kind of talking about growing up in this one place and what this was like and that was like. I said, you know that he just like kidnapped these people. I said, yeah, he's still a human being and I'm going to treat everybody with compassion. Like, whoa. So that was an example of modeling behavior for these moments of, yeah, that's our job.
It's not your job to be the cop or the judiciary or the jailer. Your duty in that moment is to be a doctor. I just did a podcast about duty and the Bhagavad Gita, right? And I was talking about Oppenheimer and how he was thinking about, should I build the bomb? Should I not build the bomb? And he built the bomb because it was what he had control over, whether or not this spirals out into nuclear war or not. This is what he had control over. And you're sort of saying the same thing, although, and maybe in the moment it makes sense. Maybe in the moment you're able to overcome that and actually do your duty, but it certainly does put, I've talked to a lot of bad people in my life too, right? I've interviewed murderers. I've interviewed cult leaders. I've interviewed these people who are really bad, but in my role as a journalist, I have to empathize with them and I have to ask myself, why do they think they're a good person? Right. Mm-hmm. You probably don't have to ask that question. You have to be like, how do I stop their bleeding? Right.
Well, yeah, we'll get to that. But to your point, that at that moment, kind of opened my eyes to say, one of my jobs is to have compassion for everyone who comes in, and just compassion and thinking, just like I want to be well and happy, I want you to be well and happy. And when somebody is spewing invective at you and which happens a lot in the emergency department, people could be psychotic, or maybe they just have a personality disorder, maybe they're just having a bad day and they're screaming. Right. And you think that, hey, I'm just here to help you. That's not okay for you to do that. We're going to set some boundaries, but I'm still going to help you. Mm-hmm. So back to this moment, we're talking about these intense moments. This one really sticks out. So we've got the ambulance coming in and there's one officer who's been shot multiple times and they can't control the bleeding. I think, whoa, these are paramedics. They're the best in the world at stopping the bleeding.
Right. That's their job. The paramedics' job is to stop the bleeding. That's what they do.
They are great. And so we have everybody there. We've got me, my partner stayed there. A surgeon came in, the orthopedic surgeon came in, just everybody waiting. And there's multiple gunshot wounds. We've got blood going and all the things that you do in a trauma. But what happened was there was a femoral artery.
That's the big artery in your leg. Yeah.
The big artery in the leg. Did you see Black Hawk Down?
Yes.
Do you remember when he's using the hemostats and he's operating on his groin area? That's what was injured in that. And that guy died because he couldn't stop the bleeding from the femoral artery.
Yeah. I mean, that's one thing that I've trained for like combat journalism stuff. Like there's this medical program called Risk where we, journalists get in shady positions, unfortunately, too often. And, Sebastian Younger's partner, and his name is somehow missing me right now, but he got it. There was he was in, I want to say, Libya. And there was a bomb went off. He might've been in Iraq. A bomb went off. He got his femoral artery severed, and he bled out. And there were journalists with him, and he probably could have been saved if people had known to, well-aimed direct pressure, stop the bleeding at all costs. Like, I mean, there's some things that you train in as a sort of first responder. And basically, for all of you who have not done first responder training, the goal is to plug up the holes. That's what you do. You plug up the holes however you can. Stuff a tie in that wound, put a tampon in there, and put pressure on it so that the blood doesn't leave. Because when you worry about what the doctor will do later.
Right. Stop the bleed. Stop. There it is. And that actually is a major change in how we did resuscitation. It used to be airway, breathing, circulation. Now it is circulation, airway, breathing, circulation. So stop the bleeding first, because if you don't got the blood, nothing else is going to matter.
Yeah, so you can't survive long without blood.
You can't. It turns out you can't survive long. So I was the trauma team leader in this, and we're looking at the whole situation. You assess it very quickly and could see that there was direct pressure over the femoral artery, but it was still bleeding through, and he was bleeding out. And would have been great to have combat gauze, or Israeli gauze, which is basically this gauze that is impregnated with blood clotting agents.
Yeah.
Would have been great to have that. Didn't have that. So I stuffed a bunch of gauze in this hole, put pressure on it.
Wait, you don't have that at an ER? You don't have?
We didn't have it at that time. They have it now. Yes, you should have. I mean, you'd think of like, what's the one place you'd want to have this? Yeah. We didn't have it at that time. So it's put in regular gauze, and that didn't work. And putting pressure on it, and it was it was a big injury to the femoral artery. And so wrap some gauze around my finger and then put my finger as deep as I could into this hole, because the bullet had taken this angular trajectory and found the hole in the femoral artery, and just put my finger on top of it. And then the bleeding stopped. But now, like, we're doing this whole resuscitation, and I've got my finger on this thing. And it's like, I can't really take it out and have somebody replace it, because you can't see it, and maybe it won't stop again. So I kept my finger there for about an hour while we were doing the initial repairs, and then got to go to the operating room to fix this thing.
Mm-hmm.
And so, like, well, what do I do here? And they said, just keep your finger on that thing. And so, and this was surreal. I've never had an experience like this. So I've got my finger. It's funny, as I'm telling the story, I had my finger just like here, just the muscle memory of that moment. So I've got my finger on the artery, and we're going into the operating room, and I'm kneeling on there, and he's still awake, and we're going through this, and we get into the operating room, and everybody's kind of gowning up, and they're doing all of the prep. And this whole thing, a whole prep is happening around my finger and around his groin. And they're doing all the sterile stuff, and they're sterilizing my finger and putting things over top of me. And the surgeons come out. Now they got their knives, got all these things. And I'm getting really nervous. Actually, I got chills thinking about this moment of what is going to happen here. And I said, okay, now it's time to release. And we're probably about an hour and a half into this now, like getting him prepped in the operating room. And so I was like, are you sure? Are you sure? Because eventually you're going to have to do it. So I pull my finger out, and then they get their whatever their instrument is in there, and they stop the bleeding, and then they fix it. But that was not a cognitively challenging moment, but that was kind of this, I guess, almost spiritually and emotionally challenging moment of, well, this is just it. And not that I haven't done things like this hundreds, if not thousands of times, but it just felt like this moment of life is on the line on this tiny little point on this artery. So I'm not sure where that story concludes or how that concludes or the message, but there's an example of.
It's interesting because it stuck with you, and I assume that you have saved other lives in your time, right? But you're saved it outside of your own normal expertise, right?
Yeah.
You found the problem and you plugged it up, but you're, as an emergency room doctor, you're someone who likes to take action, right?
Yes.
You're someone who there's an issue here and I can resolve this issue, but instead you had to get stuck in that issue. And it's probably why you and there was nothing you could do. You just your whole action was to sit there, and you had to be parasympathetic in a sympathetic environment, and that was probably, and there was also, of course, lives on the line. There was chaos around you, but there was nothing you could do, which is probably why that created such a powerful emotional imprint, I would guess. Scott Carney, Wedge psychologist, unlicensed by anyone.
Yeah. And I can remember thinking, actually, I had, and since that was many years ago, but since that moment, I hadn't thought of this. I can remember just thinking over and over and over again, please don't die. Please don't die. Please don't die. Because it was, when you're taking action and you're doing all these things and you're doing all these procedures, you're just focused and you're kind of compartmentalized. But here, there was nothing else. There was nothing else to do except sit there and talk to the other team members and help direct things. But yeah, I think to your point, that's probably what that is. Sitting there and not really doing anything else is what put the stamp on it.
And he lived?
Yes.
And the story has a happy ending, guys. All right, I'm gonna hit this ballpark signal. Oh, you hear this? Okay, yeah, okay, good. I thought it was going to be a crowd cheering. Actually, I'm sorry about that. There's a sound effect option here, and that was the wrong one. Oh shit. Oh man. Okay, we have a little time left in the show.
Okay.
And I had this question that I think is sort of appropriate to. Well, there's two questions, and I'm going to let you. Maybe you want to go both of them. Maybe you want to just do one. I have time because all I have to do is, take laxatives in 2 hours. If that's
you could start now. Let's do it now. We'll do like a marathon.
Oh my God. And Scott's now not present in front of it's just me talking. It's just you, Rob, and Scott is somewhere else. Okay. I have several friends who are ER doctors. And my father worked in ER for decades. My grandfather worked in ER for decades, and my great grandfather ran a hospital. So I have a lot of ER going on in my life. And one conversation that I've had somewhat recently with a friend of mine was about the drug ketamine, which is this, I guess you could call it a dissociative drug. And well, I don't know a ton. I've never done it. I have friends who use it recreationally, which I have some questions about. And there's a ton of recent psychological research showing that ketamine is incredibly useful for reducing the effects of PTSD and depression. And they give macro doses of ketamine to people, and for some people come out saying that it's changed their lives entirely. You, as an ER doctor, have a very different, I would assume, a very different view of ketamine. And I was wondering what you can tell me about how it's used in the ER and why, if you have an opinion on this, why it might be also useful psychologically.
I think they're all part of the same spectrum of effect of ketamine, with the ability to dissociate, basically detaches you from your ego.
Mhm.
In fact, it's called a dissociative agent.
Mhm.
And in the ER, so we'll come away from ketamine clinics and the other uses of it. In the emergency department, how it's primarily used is for procedural sedation. You want somebody to be asleep, basically, for 20 minutes,
Mhm.
or for intubation, where you need to put an airway into somebody. You need to put an endotracheal tube in their mouth, and then you need to breathe for them. There's other uses for it as well, but those are the main ones. And one of the incredible things about ketamine is, for the most part, you can give somebody a pretty good slug of it and they keep breathing. And
Mm.
so to that point, it's been started to be used as what you would call a chemical takedown. So somebody comes in out of control. They're
Mm.
on meth and they're violent, and you want them to go to sleep and come out
Mm.
of it. There's many different ways to do this, but one of the more common and more recent ones is a big slug of ketamine,
Mm.
500 milligrams of ketamine, which is, so if we were going to put a 70 kilogram man out, that would be 280 milligrams of ketamine. Pretty
Oh,
big.
so you
500
double it.
milligrams,
Yeah.
just give it this. And for people do stop breathing, because that can happen, but for the most
Mhm.
part, they keep breathing. And you put them on all kinds of airway stuff to make sure that they are still breathing, that their oxygen's okay, and
Mhm.
they're not losing their airway. So those are the three main things that I have used it for and seen it used for. And that one of the incredible things is that it's just so predictable, and it
Mm.
is that maintaining of the airway. So for procedures, for me, one of the more common ones was a facial laceration in a child. And
Right.
what I
I've heard for children, it's incredibly, but the people, ER uses ketamine for kids all the time because they're so hard to use other anesthesias for.
Yes, yes, and it was a real game changer when we started using it quite a bit. So
Mhm.
what I used to do, and this is gonna sound horrible, is when a child would have a facial laceration, you had this thing called a papoose, and you'd wrap them in a sheet like a burrito, and then you
Mhm.
Velcro them down, and then someone would hold their head, and then for the next half an hour, you would be sewing while the kid would be crying and screaming.
Oh my god.
It was horrible. It was horrible for
Yeah.
everybody, especially horrible for the kid. And so as I got on in my career, I would say to parents, even especially if it was a lip laceration or anything that was going to require more than one stitch, I want to get a perfect closure for this, and it's going to be best if they are as relaxed as possible. And I'd ask, you think that they're going to be able to be relaxed and still? Usually the answer was no. Or if the answer was yes,
Mhm.
then was often they still weren't. Then I'd
Right.
recommend ketamine, and we'd give ketamine for that. And before you go into ketamine, give them some suggestion. And I don't know if there's evidence for this, so a lightly held belief, because you're going to dissociate and kind of go into a dream
Mhm.
state here. You turn down the lights and everybody starts speaking calmly. It's
Hmm.
just like with the psychedelic experience where there is the set and the setting.
Mhm.
If you go down with all of the bing, bing, bong, bong bright lights, that's going to be a different experience than, hey, things are calm, the lights are dim, and here I am speaking really chill in your ear. And I want you to tell me, who's your favorite superhero? What would you
Mhm.
like to do? What would you do if you were that superhero? I want you to start thinking about that. Thinking about if you could fly like Superman, or you had
Mhm.
Thor's hammer. What would you do? What would that be like? And then you start talking as they get the ketamine and you go into this dream state. And you find that oftentimes they would have the dream, or they would have this experience that they were this superhero. And it was incredible.
Right.
And then when the data came out, the very first data came out that ketamine might be applicable to depression or useful for depression, I'm thinking, oh, come on, this is crazy. This could be cool, but this is crazy. Just like the vaginal egg. I think there
Right.
was actual evidence. But that was quite a while ago with this group of people that, wow, why would you think to use ketamine for depression? And it's suicidal ideation. And it was just so incredibly impactful. And now we see what's going on. And that's since led to ketamine clinics and the like. So I'm not sure if that answered your question about the
Well,
ketamine experience, but we can dig deeper.
it's super fascinating that an anesthesia that works because of a mental change in the person, right? A dissociative doesn't necessarily mean that you don't feel the pain. It's just that you don't experience the pain. And I think that maybe that almost sounds like semantic foolery here, but it's not. It's like you distance your ego, your awareness, your watcher, the I think in Sanskrit, the parusa, the thing that witnesses, and it moves back, and the pain still may happen at some part in the brain, but the thing that contains that pain is not looking at it. And whereas something like a propofol or a morphine, they work on entirely different mechanisms. And I've heard, and this is I've heard, but I don't know. So this is me talking to people who've been through these experiences. But like the trauma in surgery, so when you cut someone open and you're taking things out, and it's a pretty violent in a way, or at least traumatic experience, like physically traumatic experience, that some people, some part of the brain remembers that trauma, and there's a PTSD that occurs after surgery. I mean, really common after open heart surgery, that people are depressed for years afterwards, and it could be related to this trauma, whereas a dissociative may put you in a place where maybe you don't, you see the trauma, but you don't experience that trauma. Maybe.
That brings to mind another aspect of ketamine, which is kind of this razor's edge of it can also be used for pain at low levels, especially in trauma patients when you're giving multiple doses of pain medication. Ketamine can be incredibly effective. But to your point, say for a kid who you're sewing a laceration, sewing a cut on their face, you will inject anesthetic because, yeah, that pain might still be there. But there is this zone that I don't know if it gets talked about much, which is called partial dissociation. So you have Scott Carney, you right now with your ego formation within you that I am Scott Carney. And then you have with the ketamine, the full dissociation. Well, there's a mid dose. If you go, it's just above that pain dose before you have somebody start going to sleep, where you can have partial dissociation, where you're just not quite there. And you're aware of this absolutely dysphoric experience. And it's horrific when I've seen it. And what it usually is, and this is why in a ketamine clinic that's giving IV ketamine, they're giving it as a slow drip. So you might actually be getting a dose that could cause that. But because it's a slow drip, you're very unlikely to get it because your body's getting it gently. But in the emergency department, you're going to get it much more quickly, and you're going to get it as a bolus. And then you get into this partly dissociated states. And then people come out of that and they say, that was the worst thing. There were just hallucinations and spiders, and I thought I was going to die, but I was still here.
Oh my God.
Ooh, yeah, that's what you want to avoid. Is that middle ground.
Yeah. Well, I do know people who take ketamine recreationally, and I see it as a dangerous drug, right? I see it as, I mean, I think that they're clinically, I think there's some really interesting things to be done with it under supervision. But there's this dark energy around some people I know who've done a lot of ketamine that, yeah, I mean, I've never personally done it. I've never actually that's never been a draw for me, but I felt that maybe those mid-level dissociations, some people might find them pleasurable, even if they go to a dark place. I don't know. Scott Carney is not going to investigate that.
Scott Carney does not investigate ketamine.
I mean, I don't think so. I mean, I don't have a mental issue that I necessarily want to work with at the moment. Rob, this has been a really great conversation. There was one other thing that we were going to talk about, but I think I want to hold it off to the next time we do a show together, which will probably happen at some point. And for everyone who, again, we're getting towards the end of this podcast. Our time together is drawing close. And remember, Rob Orman's Stimulus podcast is a place where he can talk to you about rectal foreign bodies and vaginal eggs and
I don't talk about that anymore, man.
and how to plug up bleeding arteries. And also he does coaching. Yes, that's right. Rob Orman also does coaching, and somehow that all fits together. It really does in this beautiful way.
Somehow there's a union of amazingness with all that.
Awesome. Well, thank you so much for being here. And, I'm sure we'll be in touch again soon. From PokeyBear LLC in Denver, Colorado, this was Scott Carney Investigates.